We are recording, so make sure you watch your eye rolls, watch your hand motions, because it will not be deleted. So without further ado, again, my name is Micah Hunt. I am your host with the most of these virtual presentation Fridays that we hold every Friday with a free hour of CEUs to our professionals that require them to keep their license and to keep their certifications up to date, providing education, information, and resources in the community across the country. And again, thanks to Vala for that opportunity to have those CEUs provided to you all. They do all the legwork and all the handling. And so we've been doing these since May of last year. We're almost a year in on this, which I can't believe it's already been almost a year since we've been doing this every Friday. And then, of course, we have our big virtual conference that I'm really excited about next month, which is a week long for ability to get 9 CU credits. More on that after this call. So stay tuned for more on that. And so we just want to say thank you to Vala and all of you for participating in this. Now, I am actually not having to do a whole lot of work this time, which is a little weird. So I'm actually going to hand it off to Cheryl Slavinsky, who is on my left, but I don't know where she is on your screen. So wherever she is, but she's going to be moderating this, and I'm going to let her handle the introductions of our amazing panelists. Cheryl, I am now muting myself. Cheryl, you're muted. So all that you said with that excitement, okay, you need to start over.
You can tell I'm a professional. Mike, thank you so much for the opportunity to be here. We all appreciate it. And for everybody out there, I know you have a million other places you could be this morning. So thank you very much for being here. I'm going to jump right into our panel. I'll just give a real quick introduction, but Glen Rundell is with us, the CEO of National Physiatry. And we've got Gary Jones, the Executive General Manager of Customer Experience at VCPI, and Dr. Deborah Oranchak, who is a physiatrist. So that's real exciting because we've got a techie person and a doctor, and we're just gonna have some fun and write down your questions, send them to Micah, whatever. I'll just repeat the name of what we're talking about this morning. We're talking about physiatry and post-acute rehab in this age of COVID-19. And now, of course, we're in all different phases of that. So we've got some post-COVID patients and whatever. But Glen, I'm going to start with you because let's just get some vocabulary out of the way. We've got a wide range of people in the audience. Not everybody knows what physiatry is or a physiatrist does or who they are. So why don't you get us started and explain what physiatry is and who practices that kind of medicine?
Sure. Thanks, Cheryl. Thanks, Micah. Good to see you all. Physiatrists are specialists in rehab, and it really comes down to picking your specialty as you're going through medical school and residency. And so cardiology is the heart, pulmonology is lungs and respiratory. And then we've got physiatry, which is really the study of rehab and the ability to provide a higher level of medical care when folks are either in recovery or in rehab for whatever number of reasons. It's a very holistic approach. So there's psychological items that they deal with. There are all kinds of afflictions that may occur that would be more disease-like. Then there are slips and falls, and so it really runs the gamut. But it's it completes somewhat of a circle of primary care, surgeon, providing, and then recovery and best outcomes, and providing those patients with that whole continuum of care that gets them back to their home and in the best possible fashion. Really, we're looking to achieve previous levels of function, which is really key for most of our physiatrists. So physiatry is just very holistic. It's a piece of the entire process that occurs through our lives, and it's a very important one. So we're very excited about what we've done in the past, and a little perplexed about how things are going in the future. But doing taking that extra step to really assist in the COVID kind of side.
Thank you. Dr. Oranchak, and I'll call you Dr. O after this. We're especially happy to have you this morning because you're the boots on the ground, and I don't know if you're doing much of that with telehealth today, but you're board certified specialist in physical medicine and rehabilitation. So one of the things I've heard is that the physiatrist reunites the doctor with the patient. Can you just tell me what that means and a little bit why it's beneficial in skilled nursing and rehab? And I understand you like to work in post-acute, and you've been working for clinical experience 18 years. So give us your take on this, on what it is you do. And
I really think of physiatry as sort of a bridge between internal medicine and therapeutic medicine with physical, occupational, and speech therapy. And it's really involves a lot of communication, a lot of teamwork. It's very interdisciplinary, and that's what I like so much about it. It drew me to the profession because it is really a group of people sort of led by the physiatrist, helping somebody to get back to their life after a prolonged illness or an injury, any kind of trauma. It's really trying to get the person back to their prior functional level. And it's really, I find what really matters to people, it's working very closely with family members also and helping them to integrate into getting back home and working together on getting better.
great, thank you. Gary, I'm thrilled always to have you here from the tech side. And with VCPI, I want you to help us lay a groundwork, a framework for the whole telehealth thing, because there's a lot of things that have to happen on your end, technology-wise, or what people should be thinking about. So can you help us just lay a groundwork? I've heard you talk about this before.
Yeah, for sure. Thanks for having me, everybody. I think there's a couple things we want to make sure just kind of we talk about initially. So as we're talking about physiatry, we're talking about obviously providing care for people and support for people. So obviously for everyone here, you guys are all familiar with the challenges of COVID every single day. So that poses an additional challenge of how do we do this in a world where we're not necessarily in front of people. So I think that's where, my goal today is to kind of share with you guys what we're doing and what we're seeing in the industry as we look at how technology can help us overcome some of those challenges. So I think initially when we think about what does a groundwork look like, what does a foundation look like for being able to provide, whether it's telephysiatry, telehealth, or telemedicine services inside facilities, whether they're skilled facilities, assisted living, or independent living. There's certain things that we need to be thinking about. And I think that with COVID, there's been a lot of support for funding for a lot of different things where you guys might have, some CMP funding for tablet devices inside the facility to help expedite that and to allow you guys to have the opportunity to do some of these things and offer some of these services. But really, the things that we really just want to keep in mind as you guys are looking at rolling some of this stuff out is, do you guys have the infrastructure to support it? Do you guys have buy-in from leadership? Are you guys communicating with whether it's your IT partner or internal IT to make sure that you guys are doing this in a meaningful way? I think one of the biggest things that I see, and I think the scariest things is when you start just buying devices and you say, we're gonna set up an iPad here and a tablet there for telehealth. If you're not engaging the right people from a security perspective, you run into compliance concerns and compliance issues that really can put the business at risk. So those are some of the things you would definitely want to keep in mind as you really kind of think about that. And then I think overall, really when we think about all of this, whatever solution you guys are using has to be simple, and you have to be able to train your staff. And I'm sure you guys know that already, that training is such a critical component, whether it's the initial training or continuing ongoing training for your staff members. It's so important that folks know how to use stuff. If they don't, people aren't going to adopt it. And I think we all know that. It happens every single day when you guys might get someone might usher in a new technology that no one bought into and no one really has proper training of. So it's very difficult for folks within the facility that are actually providing care to be able to adopt some of those things. So I think there's definitely some critical things we want to keep in mind. So I think that just kind of allows us to lay the foundation.
Great, thanks, Gary. Glenn, I want to jump back to you now. Now we've got some of the basics down, and we're, kind of who physiatrists are and what they do and where they work. But I would like you to talk about this special time in history and how the pandemic really became the perfect storm to put physiatrists and telehealth together. So can you take us back to last March and what happened and why everything changed in a heartbeat?
Sure. As we all know, I mean, I think it actually even came out today that I think today or yesterday, or it could be tomorrow, but the first case was reported. So it was obviously very early on that we didn't know what we were reporting. So continuing to go forward as we had in the previous 10 months, we had already started establishing a telehealth, telephysiatry program, telerehab program, just in order to satisfy and to provide those services in locations that would be remote or patients that weren't able to support a physician exclusively within their area or their region. So it was a combination of being able to have some face-to-face and some telerehab, and it was all new. I mean, it's been around a long time, but it was all new with the rehab side of it and those kinds of things. So Gary really introduced us to some really great opportunities as we were going through it. But as March came, things changed, and facilities stopped admitting new patients, and everybody was in a situation that even the best physicians and the smartest people in the room didn't know what the plan was. So as we went through last March and got through the year, we started to see some of the effects of COVID, which have, it's an infectious disease. And so we're dealing with a team of physicians and a team of therapists and nurses and that are really taking control of this and exercising, I guess, their best practices in each of their specialties. So really the opportunity came just to continue to provide services like we always have. It's just a new, it was really a new barrier for us to try to break through. And it's been exciting from the standpoint of being able to treat people and provide them with the best services, because really that's where physiatry comes into play. So you've got the primary physician who is treating this patient, may see them first. You've got pulmonary, you've got cardiology, you've got physiatry. They're all working together with a therapy team and a nursing team in order to provide these better outcomes, and also to get them discharged back home at those previous levels of function that we've discussed. So it's a new ball game out there for us as we see it. And I think telehealth, telerehab, telephysiatry, all of, in any way, shape, or fashion you want to call it, is going to continue down the road. And the security levels have been great. And we've had a really good experience with BCPI in providing that better than we had prior to this. So what I see is it continuing for quite some time. And we'll have to identify new infectious diseases and new morphing of just the COVID-19, which is already occurring. And so there's a lot to digest, I guess, but there's a huge need for that final, icing on the cake, which is providing that recovery period, getting them back to those previous levels. and then getting them back to, functioning in a normal level that they had previously been functioning at. So yeah, it's an interesting time in history. There's no doubt about it.
Gary, I'm going to ask you, Glenn, what I was really looking for, and people in the audience may or may not know, telehealth was not reimbursable before COVID came along. It was if you were in, like Glenn said, outlying areas or rural areas. But Gary, I would imagine, and Dr. O, put your lives in a spin because Gary, you were not providing telehealth in this setting, right?
Yep. Yeah, that's correct. Yeah. Obviously everyone knows that the world's very different, but I think there's definitely opportunities that came about due to COVID. And I think CMS and the federal government allowing for facilities to get reimbursement for services that happen over video. I think it's really as simple as that. And I think there was always barriers before, but with COVID, coming about, it really opened up the door. And I truly feel, and I think a lot of other experts feel that, this is kind of the future, and we don't expect things to really revert. We expect them to continue to kind of open the door for some additional things moving forward, which I think is really critical, because what that means for communities is that, technology is here to stay. And I think in the industry, truthfully, it's always been a challenge. If you compared, the post-acute care industry or the senior living industry to any other industry, even other healthcare subverticals, you would look at those specific industries as very slow to adopt technology. But with COVID, it's changed the game a lot, and people have had to start adopting technology in droves, essentially. And I think that's really changed how it's changed so much with the industry. But I think that's really critical to consider, because it now is kind of table stakes for a facility to be able to offer solutions like that. Like when I think about, obviously everyone's dealing with, admissions at an all-time low. When you're looking at how do we fight for potential residents to come into our facility, some of the things that family members are looking for are, do you have technology solutions to allow my mother or father to communicate with me, but also to communicate with doctors? Those are things people are looking for, because they don't necessarily want to be in facilities 24/7 like they maybe have been in the past, or visiting their loved ones on a regular basis. So those essentially are table stakes, and the landscape's more competitive today than it ever has been, due to the fact that, occupancy is at an all-time low right now. So I think there's a lot of things that we have to consider, but I truly feel that it created a really good opportunity for us to look at technology holistically.
Great. Dr. O, one of the things that happened pretty much around the same time that telehealth became available, and maybe shortly after, in a month or so, was that as the hospitals stopped elective surgeries, and all of a sudden there were more physiatrists looking for work than there ever were before. So we not only had physiatry being reimbursable, but all of a sudden we had physiatrists that wanted to work. And I don't know where you've worked for 18 years, but your life changed a little bit, because I would imagine that this was the first time that you've done maybe a combination of face-to-face care and telehealth in this setting. So can you just talk about how your life changed and what happened to you?
Right, exactly, Cheryl. It was sort of, I had to sort of adapt my skills from face-to-face into a telemedicine format. And those skills are still evolving, and I'm learning new things all of the time as to how to better communicate with a patient, how to better communicate with staff who's on site, and just to try to integrate all that information and help a patient through whatever problem they're dealing with, and communicate with them, some solutions that can help from all members of the treatment team. So it's been challenging, but it's definitely been rewarding. I feel that, especially in the time of COVID, it gives people some kind of contact from a physician, that they feel listened to. They feel like their concerns have been addressed, and that's been nice to be a part of when you can't actually be in the building because of infection concerns and protocols and things, which really shook things up a lot in the post-acute world. And we just wanted to find the best ways to provide care in a way that was meaningful to a patient and meaningful to other members of the staff.
And what I've heard from people is that one of the things they appreciated most about physiatrists during this time was that communication with the family.
Definitely.
It was, you know, it was a doctor that could really tell them everything, look at the whole thing holistically. So great. Glen, let's go back and let's talk a little bit more about the overall benefits of physiatry in general, but what physiatry brings to the skilled nursing and rehab setting that's just a little bit different. In other words, like how do they bring value to the healthcare setting? You can take that any way you want, or answer a different question.
So we'll let Deborah answer that question because she's in there every day. No, I'll share a little bit, but she
I was
knows
going to ask her to add to it.
Where we're at. Absolutely. There are many benefits, and the value is indescribable of what you get. And it's been one of those scenarios that the reason that we don't hear or see physiatrists that often is that, you know, you generally had to be in the hospital with an acute, you know, kind of condition, and subacute conditions weren't high priority, I guess is what I would call it. But as time went on and as things developed and technology came along, even within the clinical side, it's really become a driving force within these facilities, these rehab facilities, short-term and acute. But you know, if we really focus on short-term, it's pretty amazing where they have come today. So the experience of the past has been, you know, your mother or your aunt or goes to the skilled nursing facility in long-term care, has a, you know, slip and fall and starts to experience these things. And you've got a fantastic therapy team and nursing team and administration team, but you're just missing that one ingredient. And that one ingredient is the specialist in rehab. And just like they would have in any other specialty in medicine. So they have become, you know, the ones who which are the driving force, which are setting plans with the primary care, setting the plans with the therapy team, then monitoring those plans and monitoring either improvement during that period of time, or, you know, sometimes more importantly, identifying decline and stopping it. And so that's something that was missing for a long time, and it's probably the biggest benefit is really the patient's benefit, the family's benefit, in terms of communication levels, and so it certainly was missed for many years, and is being looked at a lot more closely, I guess, as a high level importance. They were just admitted into the American Medical Association as, you'd have to, I think it's the RUC level, Dr. O, but you know, the recognition that physiatrists have gotten in the past has been lacking, and has over the last, I would say more like 7 to 5 years, has been pretty incredible. So we're seeing better and better results, better discharge, better quality of life. So it's good all the way around. It's hard to come up with you know, things that aren't benefits and aren't values.
Dr. O, thank you, Glen. Dr. O, I would like you to add to that. And isn't one of the big benefits helping to reduce rehospitalizations?
Exactly. We're trying to help improve the level of function and improve endurance, and, you know, maintain levels of activity and improve their quality of life in trying to prevent further decline after a significant illness or an injury. We want to maintain that level of function and make sure that that carries over into the home setting. So that's why family education is important as well. A lot of patients go home from post-acute rehab with visiting nurse services and therapy at home as well. But again, those services have been more sporadic at this time because of the pandemic. So that's been difficult to help tie all of that together. We want the patient's progress to continue upon discharge from a rehab setting. And a lot of it, we have a lot of interdisciplinary team members who help tie all of that together. But you know, we don't want to have somebody undergo such a course of rehab where they made such improvements after their illness and then start to go backwards. We really look to avoid that at all possible.
Has it been hard to do through telehealth?
It is, and it's a lot of it is communication also with social work staff and the therapy team, and just sort of helping to integrate everything and to explain to family members what level of progress a patient has made and what they were having difficulty with, what types of services they would need at home, what type of equipment they would need. And so it's helping to tie all of those things together. And Cheryl, you mentioned something really important earlier, and that is that elective surgeries were halted.
Right.
You know, maybe postponed to sometime in the future for when the hospital is able to handle those things. And that's a big issue as well, because a lot of these patients were waiting for, I'll use orthopedic surgeries as a primary example. People with chronic knee and hip pain awaiting their orthopedic surgeries, hip or knee replacements. They have just been postponed. So that just means somebody continues on in pain. And then they get weaker and weaker because their mobility has been decreased. And they're not able to maintain their prior level of function because of their degree of pain. And so I think that's important that physiatry is really involved in pain management as well, including medication management, some modality treatments, just topical treatments. It runs the gamut of trying to find any kind of relief for somebody who is in pain and trying to perform their daily activities.
Thank you. Yeah, I guess a lot of the hospitals started to open up again, and now it's like they're all closing again. I don't know if anybody else has noticed, there's a lot of publicity on television right now about, if you're experiencing any of the symptoms of heart attack or stroke, people are afraid to do anything, or they know that they can't even get into their hospital. So we just are kind of spinning around in a dryer. Let's see, Gary. What's you've been at this from all sides now. What's the reception you've been seeing, from your end as far as telehealth and adoption, or barriers or challenges, or yay, we love it.
Yeah, I think there's a couple of things that we can look at. We can look at, the benefits and what people are seeing from the benefit side. Obviously, we're able to connect with people, which is something we maybe didn't have access to when COVID first came about in early March. So I think that opens up the door for some other opportunities as well, whether it's, engagement platforms where residents are communicating with families, or anything similar to that. So there's definitely a lot of positives. There's definitely challenges too. I think I mentioned earlier, training as a critical challenge in adopting a telehealth or telerehab solution, or any telemedicine solution, because we want to make sure that the staff are properly trained on how to use something. And then we know also that, another challenge in the industry is turnover and staffing in general. So we've got to make sure that we have an easy mechanism to continue to train people as new folks come on board. Other challenges too, I think this is one of the things that I saw a lot with facilities that were just, they were going out and buying iPads or tablets at Best Buy. They were using CMP funding to do that, which is great. It's something that we want to take advantage of. But they were just putting these devices in the community without connecting with their internal IT team if they had one, or if their IT partner, which they likely have one of those two. And the reason being is just due to compliance and security. When we think about the potential for EPHI to be on a device, If that device got in the hands of somebody that wasn't supposed to access it, or left the facility is liable because they're the ones that are providing that solution for the staff members and for the residents. So we really want to make sure that there's security wrapped around what you're going to be delivering. So when we talk about, opportunities, I think one of the other ones is really building partnerships with folks, whether it's with your internal IT or your IT partner, to build out a strategy. So you're not just going out and buying things and doing things in a silo, but doing things in conjunction or coordination with the rest of the organization, whether it's a larger company or whether it's a single mom and pop facility. And I think those are some of the things that we were seeing. And then also, I had a client just recently ask me that, we're looking forward to the future. We want to make sure that as we build this new facility, we're allocating the right amount of bandwidth from our internet provider to be able to do things like telehealth and telerehab. And I think that's really interesting, because 10 years ago, if you asked me that question, people wouldn't be thinking about that. And the fact that people are thinking about it today says a lot about where we're going and how technology has kind of laid the foundation for how we can provide better care in facilities. So whether it's, automating things so staff members can focus on providing care for residents, or using these technology tools to help support that care. I think there's a lot of things that we're seeing that are potential benefits that didn't exist 5 to 10 years ago.
Yeah, I agree. I know I've heard you talk before about just how many devices the average resident moves in with, and I don't know what the figure is at now. What's like 7?
Yeah, 7 to 10, I think, is the most recent numbers within the facility. And that varies. It's not just going to be like your tablet or a smartphone. It's going to be the TV that you have that connects to Netflix. It's going to be your little Amazon device that that someone's talking into, hey, Alexa, or your Google device. So it's all of those things, but it just goes to show you that, the landscape's changing. The people that are coming into communities are looking for things that are different. So when one of my clients asks me about bandwidth, they're thinking about it, I think, in the right way, because they're thinking about, okay, we want to provide something, but we also, like most of the facilities and most of what you guys experience today too, is that, residents want to get on the internet in the facility. They want to watch Netflix. They want to FaceTime with their family. They want to Skype with their family. So we got to make sure that we're accounting for all those things. And I think that, going back to what I mentioned before, the foundation, the plan, strategizing is so critical, and doing that as early as possible, because without a plan, it's just going to be things get implemented willy-nilly, and there's not really coordination. And then what ends up happening, what I've seen 9 times out of 10 is they lose adoption. So you implement something, and then over time, if you're not accounting for all these things and planning for them and the ongoing use and maintenance and costs associated with them, then people aren't going to use them. So essentially, you're spending money for no reason, implementing something that is, one, taking time away from your residents because you're trying to show them how to use something. And at the end of the day, if you're not planning for the ongoing use of that, I mean, we're essentially just wasting time that people could honestly be better spending time with residents. So if you're going to implement technology, you have to do it in a thoughtful way. Otherwise, I would say have a plan that maybe doesn't involve something that's really intricate or robust, so your staff members can focus on the things that are important, because technology shouldn't be a barrier. It should be a component that really elevates care. I think that's one of the critical things, is like oftentimes it is a barrier, and that's when we're looking at it, I think, in the wrong way.
So we don't want to just have a tech strategy that does not align with our business strategy. It should all kind of work together. Right?
Certainly. Yep.
Great. Dr. O, let's talk about some of the after effects of COVID, because you have been COVID trained, whatever training was available, and so you can treat patients with COVID, but also, what I keep seeing as a big opportunity for skilled nursing and rehab, and I don't know, somebody can argue with me, but it seems to me that, so many of these post-COVID patients are having problems, whether it's swallowing, it's mobility, or whatever. Talk a little bit about that and what you've been seeing and about that ability for physiatrists to handle those kind of patients.
Sure.
It might just be short term.
It's been a very interesting learning process for me, actually. Learning about COVID-19, what types of effects it has on the body, and it really can affect all organ systems. And we're seeing that as time goes by, what types of difficulties the patients are having. But the primary one is, significant debility, weakness, fatigue is tremendous. They have no appetite often, loss of the sense of smell and taste. So they have no appetite because of that. And they tend to lose weight significantly. And that's how our registered dietitians can help be involved and help with some recommendations to prevent weight loss and just keep an eye on their caloric intake. I've read recently that dysphagia is more of a problem than you would think, after somebody has been considered recovered from COVID-19. It can be a couple of months later and they develop weakness of their swallowing muscles, when they thought that they had recovered. And, so we need to pay more attention to that. I've talked to a lot of speech therapists who are involved in that now. And, they're just dealing with strategies for prevention of loss of that muscle tone and to keep their swallowing safe and to prevent pneumonia. So in addition to the physical things, there's also cognitive issues that patients are dealing with when maybe they really haven't had cognitive issues prior to this illness. So there's other organ systems involved. The kidneys can certainly be involved from COVID-19 when it is a severe case of illness. Some patients have required dialysis, at least temporarily while they're recovering. And that's a pretty dramatic thing for a patient to go through. The cardiac side effects and involvement can be significant. Patients can develop myocarditis and, as well as, prolonged pneumonia and just decreased functional capacity related to that decreased level of endurance. So any little activity will throw a patient over the edge when really what they're trying to do is just stand there for a while and brush their teeth or wash their face. And people tend not to be able to tolerate that activity level, and they may need to sit during that period of time. So we'll try to have them, sit for any activities that require excess exertion and just trying to save their stamina for other more functional activities, such as getting out of bed and walking a little bit. So it's really quite involved. And again, it's an ongoing learning process with this illness. And we keep developing ways to prevent further loss, further decline.
Yeah, I think we're hearing more about it now. As time goes on, more and more research is being done that it's not just the immediate effects or the immediate after effects. It's like people that didn't have a bad case, and then maybe months later, now they're, now they need rehab. So thank you so much for that. Glenn, I'm going to bounce back to you a little bit. I know one of the things I've always said to you, and I know I bug the crap out of you, but why do we hear, all summer long last year I was researching, and why do we hear so little about physiatrists outside of medical journals and, clinical journals? It seems like there's been very little in the mainstream press. I mean, there's been some, and, the New York Times articles and Philly Inquirer way back in the summer, maybe mentioned a physiatrist, but talk a little bit about that, and do you think that's going to improve? I mean, I think recently this week's thing that, has with the RUC has made some changes, but talk about that.
You're exactly right. I think, Cheryl, is that it's going to only improve as far as people's awareness for physiatry and physiatry services and what it really means. We can talk about podiatrists, we can talk about psychiatrists, we can go through the gamut of different specialties, but what's occurred, what originally occurred is that oftentimes they had a physician in the hospital, and the only time you really saw a physiatrist, and you may not have even seen them, it was in recovery. But oftentimes it became a rehab, either acute, in-house acute hospital, or it would be in post-acute, depending on the level of acuity that was required, and may take both, and then probably transfers into outpatient. So there were a lot of moving parts, and I think that they just didn't receive a lot of notoriety as in the years past. Certainly, it's become much, much better in terms of awareness and importance and value and benefit to patients, families. I've heard everybody speaking quite. Everybody's experience is different, but it kind of boils back down to all being the same. Oftentimes, you'll have a physician who will come in and make decisions. Pain management came up today. There are all of these sides of a physiatrist that nobody really understood or saw before. We're starting to see that again, and we're starting to, within national physiatry, we as physician providers, we've added cardiologists and pulmonologists, and I'm working with a nationwide cardiologist right now to actually put together a team of cardiologists, pulmonologists, and not psychiatrists. Psychiatrists are pretty well known within these facilities, and with physiatrists. So the three of them together with COVID and ongoing COVID issues, post, infection issues and problems that we're going to see in what I think you termed one time, Cheryl, was long haulers, which I think somebody else quoted. But what we're seeing is now the result, as opposed to just the 2-week period of quarantine and then back to work with a mask on. That's great, but there's a good portion out there that are going to continue to need rehab and treatments from some specialists, and oftentimes they're going to come back to the facility, but not the hospital, or outpatient, as I mentioned. So there's a lot of options that are out there, and that's really the only reason that we haven't heard of them, is that we haven't paid attention.
And they were mostly in hospitals, correct? Or
they were mostly in hospitals, correct? Yep.
That's what I see as so exciting for this industry as skilled nursing. The numbers are declining. I think it's a way that that people can serve. I think what's going to be a considerable population in the future. We're less than 15 minutes out from the end of this. I want to give each of you, is there anything that I've missed or an area of this that we haven't touched on that you hoped I would? Because I'd like to give you a chance to address that, and then I really want to open it up for questions from the audience.
I didn't have anything.
No.
Okay, Micah, let's open it up and see if people have questions.
There are two that are in the chat. One is from Chris Darling. Can the panelists be asked to describe what is and is not working with the primary care, post-acute, long-term care clinicians in their facilities?
What is not working?
What is and is not working with the primary care, post-acute / long-term care clinicians in their facilities?
I think maybe I can take that a little bit. If I am understanding it correctly, there tends to be a thought process of conflict between medical directors, primary care physicians, and other physicians that are coming and as consults, regardless of what their specialty is. And what I learned very, very early on was communication is the key. As long as you have an opportunity to sit down with the team separately from the doctors or together, depending on the facilities, but oftentimes it's separate, and then sit down with the primary care physicians and really just explain to them what's happening. Very simple. They want to know, what codes you're billing, and they want to know if you're taking my patient, and that's it. And they're back to really establishing a relationship with somebody who's now in the facility, 3, 4, 5 times a day, doing the review, setting the plan, writing their medical documentation, having the doctor looking at this dealing with pain management. So there's, in terms of CMS and all the regulations, if you're not dealing with pain immediately, it's a little bit of a challenge with the way that they would like things to go when they come in and do a survey and say, well, how come it took a day, to get this person up and running after, a post-op kind of scenario or something like that. So yeah, it's been a challenge in the past, but with communication, I think that we all are able to understand exactly what the benefits and the values are among the specialists in these facilities.
Thank you.
Glenn, if I could just mention that the primary physician often is the admitting physician in the post-acute setting. And some are concerned, I think, that there's overlap of services between what the physiatrist is doing and what the medical doctor is doing. And really, it's not that. It's more of a holistic, integral type of approach where physiatrists have a different focus. The internal medicine doctor who's admitting the patient is concerned about all their medications, what their current medical issues are, and how that doctor is going to help them manage that during their inpatient rehab stay. The physiatrist is looking at sort of everything from a different angle, primarily focused on neuromusculoskeletal issues, but also generalized weakness and debility, impacted by their cardiac abnormalities, their pulmonary issues, and their levels of pain. So we're looking strictly at how all of those things are impacting their functional level and their progress going forward.
Great, thank you.
Chris, did that help answer your question?
Did I answer your question?
Okay, I was gonna say you can just nod. I see you. We have another question from Mikkel, and it was, what is the best advice you can provide to a COVID patient post-SNF care who returns home or to a senior care community for maintaining their level of functioning on top of home health, etc.?
Dr. O, want to take that one?
I would ask the patient if they have any kind of home exercise equipment. Sometimes a recumbent bike is really helpful because they can be seated sort of at a little bit of an incline, and just try to increase their time that they're using the bike. Try to help, trying to keep their level of endurance up. Some developments also have, a clubhouse and an activities room, things like that. Any type of exercise they can do in those settings would be very beneficial. And if they could attend that gym type of setting with another family member or another member of that community, just so they can be together and sort of keep an eye on each other and make sure that, they're able to do their activities without, problems with dizziness, or, we're concerned about low blood pressure, things like that, or, high heart rates. So we have to really moderate their levels of activity so that they're able to continue. We don't want them to do too much too soon. So it's a lot of it's gauging their activity level upon discharge from a facility.
Great, thank you.
Does anybody else have any questions? Feel free, those of you that are willing to share your screens, raise your hand. For those that are hiding behind their screens, I'm just kidding. But if you want to use your cool little emoji hand raise, feel free to raise your hand or share your screen to show that you want to ask a question. This is your chance. You have a panelist of experts, and this is your chance to ask a question relating to this with them here. So feel free to ask. Otherwise, we'll come to a close, and you will receive their contact information. So Glen and Cheryl, I know you're used to that, but Gary Jones and Dr. Oranchak, for you, if you don't mind, I'm going to share your email or your contact info in the email that I send out. So if you all have other questions that you may have thought of over the weekend that you're really wanting to ask, but you didn't have a chance to today, you'll have their information in the email. So feel free to reach out. That's what's very valuable about this meeting, is that there's more connections and relations and discussions post Fridays. So I do hope that you follow up with them. So with that, I'm going to stop recording.